ahead.
Okay. But only from my own experience that you've all heard, and maybe from my colleagues I've heard similar ones, this wasn't sufficient for me. As a researcher also, I feel like I needed research to back this up, okay? So I did needs assessment research. What we saw is that these are all from a perspective of a provider, healthcare provider, doctors. They're like 67% of them are showing that one or more, even fewer classes where patient empathy communication skills were maybe even, tested, okay? But out of those, they also reported that scenarios where they have difficult conversation with family members, collaterals of patients, telling them what's going on, diagnosis, treatment, 53% of them was like, well, it's seldomly or even maybe never assessed. However, the opposite of the hand is that 18% of them also was satisfied. And so the majority of them are not satisfied with the rigor of the training that was given. But as most of you know, licensing board, a lot of different dimension also is based on communication skills. So where do we learn that? There's this training gap, that starting point, but it also perpetrates to further outcomes. What we're seeing is that 82% of them report that they wish they have communicated differently. Maybe I should have said something different, asked a different question, get the information from a different approach. 78% of them show I'm not certain how to respond to this patient reaction or outcome. I told them their diagnosis and then they just cried. They didn't hear me at all. So we're seeing that is really impacting healthcare services and quality of it, but it's also impacting all of us as providers also. 59% of them said their emotion from patient interaction, difficult conversation, it's really affecting their work productivity, okay? So we're seeing it expanded across multiple dimensions of how it's being affected. And this is starting from the training gap. So Stanford does a really great job. Every single year, we have actually an annual communication course that goes on. Every provider does it. Now residents do it. Medical students start to do it, and then they start to infiltrate to other disciplines too. This is a PowerPoint, okay? I just clipped it because I do the training too. And what happens is it has a clickings PowerPoint slide, just like I'm going on right now. And then it just has a reflection question. Tell me a scenario that's difficult. And then it kind of leaves it there. That's the first part. So they give some education, knowledge, and they do have a second part where they have you form into little groups and you kind of practice. But that takes time, and it takes all of you to have the same schedule, like you're all sitting here now. However, I want to show you maybe a different approach to how we are maybe adding and enhancing the communication training. This is a patient, Sarah. Think of your patient, or maybe think about this is someone of your loved one. And what are you going to do? She needs your help. She has severe anxiety. She comes in with all these problems. She couldn't stop talking about it. What are you going to do about it? So this is the time I'm going to show you the
reducing time so you don't get feedback.
I understand, doctor, but I'm just so scared that this is more serious than anxiety. What if the previous test missed something? My chest feels so tight, and I'm worried about a heart attack.
Thank you for sharing that with me. Can you describe what it felt like this time?
Dramatic pause.
It felt like a squeezing pressure in the middle of my chest, almost like an elephant sitting on it. It wasn't triggered by physical activity, and my heart felt like it skipped a beat several times throughout the day.
Okay, and just to confirm, no exertion beforehand, right? You were just sitting, and the pain suddenly happened.
Yes, exactly. I was just sitting, maybe reading something online, and it just hit me out of nowhere. No exertion at all.
And it lasted for how long?
It lasted for a couple of hours this time. I was so scared it wouldn't stop and kept thinking it must be something critical.
All right, so you've been to the ED twice this week, And they did the full workshops. The test results showed all clear.
Just because we have limited audio for the online stuff, but I think we got the idea.
I know they said everything.
Where it goes.
Hi.
So what I showed you was audio good.
Yeah, we're
What
good.
I showed you was an example of demo of how the interaction might have worked. Okay? And what you're seeing right now is we're Care Collaborative, and out of my passion of what I see from my experience, that we developed something that helped address this gap of training, okay, that we're seeing impacts have consequences. And what we see is that, as a Care Collaborative, we're an AI empathy communication training platform where you first put in a prompt, okay? You put in a scenario, just like the scenario I might have showed you. You can put in any details you like about a patient's characteristic, the discussion you have, maybe the symptom diagnosis. You put it in, and then the second step is exactly what you said. You saw it's like a Zoom conversation where there's verbal that's been recorded, but also nonverbal. I think an important piece is people's emotion. So we have that recording as part of things that you can also review back as one point. The second point is what you see here. It will give you an AI score, which is our last step after having that interaction. It shows you an AI score of different kind of dimensions, skills that you might practice on, you might want to improve, but also things that you do well. I think sometimes we focus so much on what we don't do well, especially as a trainee, but these are also things that they might do really well. So this is just a framework of AI score. And the third piece is, what you can do is, you can review it with your managers, with your supervisors, with your mentors, so that you can build up training goals, things like that, where you can have consistent feedback. So this is what Care Collaborative as a platform is showing. And this is going to be helpful for any scenario where you might have to tell someone really difficult conversation. For example, if you were having to tell a parent of a child that they have cancer and they might have low rate of survival, the only way to really save their life might be removing a limb or opening up certain parts. That's really hard to hear, no matter if it's a child or your loved one. How are you going to have that conversation? So this is a real time simulation of those scenarios where you won't go and actually see a real person and be like, whoops, said the wrong thing, or whoops, I didn't actually think of asking this question. This helps you practice over and over until you're like, okay, I feel confident enough. There might be these framework. And the good thing about the AI is it's unpredictable, which is like human. We can't script everything. We can't predict this person is going to cry if I said this. This person's going to scream at me. We can't. That's what the AI does too. It helps us with the flexibility, with the unpredictability of human responses. This is myself, and I also have my partner that came in. He's also doing our COO, and we have a developer that we're working with. Right now, what we're doing, we have a working product. As you saw what our working product does, it gives that real-time feedback, real-time simulation practice. We're actually in pilot phase right now. So we actually have a pilot partner with Stanford in an inpatient course that they're trying to give their attending doctors. And what we're hoping is that it will infiltrate from attending residents, medical students, but down to nurses or even suicide hotline call centers where they don't have as much training as us doctors and they don't have all the time for this. But they're in the front line to deal with all these difficult conversations and patients from all walks of life. You can never predict, but you can only better prepare yourself. And this is a flexible, less structured way than just our graduate medical education right now. Hopefully enhances and builds on it without removing what's already maybe there.
Great, we're great on time. Everybody has a question or comment to jump in. Pablo Morag relay for him. So this software is likely to social camouflage in autistic spectrum people. Is this the correct way? I don't know. I guess how do you manage people communicate in very different ways, in ways that often you don't intuitively understand, which is a very real issue. And our current standard of care is actually really bad anyway. But how would you think something like this could benefit such a situation? And in the meantime, Reenan, if you want to start sharing your screen getting set up. Don't worry about it. Yeah.
So I think the piece of people having different communication and characteristics, the good thing is the platform also can adapt. So you can actually have different settings where you can have a different feedback form. You can have a different way of what you want to even score in your assessment communication. Because for example, in psychiatry, we have a lot of psychiatric diagnosis and disorders, which in other fields, you might not have it. In my primary care, I see a lot of people coming in with, I can't breathe. That's their anxiety. But when I'm in psychiatry, that's different. That can actually also be tailored in our platform where we have settings where you can put in just different options of how it's communicated, how you want to be seen. And again, this is for the person to also have that self-reflection piece. So it's tailored to the person's learning in addition to, hoping that it covers as much scenarios as possible. So if it's color coded or whatever, we can.
I don't know if you described the cases. Are they like a battery of cases you produce or something? Scenarios to encounter, personalities you want? Where are they coming from?
Yeah, so you are the one putting in all of them. We have set ones that are part of the platforms that, because of my experiences, I put in some case scenarios. But if you're doing a lecture and you're the course instructor, you can set 3 of them. This is the ones, 3 of them that everyone practices because there are core skills that are needed. But in addition, you can put in all different ones. If you're just doing rounds at hospital, they're not going to be a set case scenario. They're oftentimes very complex. So you have to, and you can add in those details in the first place where you put the prompts in. Okay. So you can add in any details you like. I see a real lifetime hand.
Yeah, real life too. Okay, go ahead.
Just a quick question. You mentioned this. It's a great, idea. Just my question is about here. It is important to know the emotion of the patients, and so emotion awareness is important. Some of these emotions can be conveyed by the words and so by the text, but some cannot. For example, the facial expression, body language, and all of this can be detected by the human. And so based on this, maybe you change your communication. How do you deal with these aspects? I mean, for example, the system can understand the body language, for example, the facial expression, and because we have a lot of things that you can see the people, the patients, and based on this, maybe this will affect the communication. And you cannot understand maybe based on the words that communicated between two people.
Right.
What do you think?
Absolutely. So in our platform, we have the verbal piece, which the text is not that hard. It's transcription, I think, technology and AI. But actually, we build in the nonverbal piece with the patient simulated, and that's why you saw Sarah. We actually had to build large language model in each of the facial, muscles and things. So it took a lot of our work to build that for the patient, but also the person who's practicing, it's also being recorded your facial expressions too. And it also tracks that. Will it track it all accurately? Well, let's say, I don't know if our technology is that great, but at least there's some training data around it. And you can actually adjust the emotional intensity of the patient you want to practice with, because maybe you don't want to practice as 10 or 11 out of, 20, and you might want to practice maybe at a 2. So you can even adjust that too. In addition, right, it's all recorded. So you can actually go back and it'll kind of track all the time points with the AI scoring. All these time points, you can go back to it and see what your facial expression was even. And so you could do it with your supervisors and by yourself too.
Thank you.
Sure, who's self-motivated enough to do that, even though that probably would be good. I'm trying to squeeze in one last question. Pablo Moore, do you want to jump in? Otherwise, I'll ask your question for you. Something about humanities. What's be better with humanities learning, not just alone ethics, philosophy, and medicine? I mean, when is the right way to teach these kinds of skills? Maybe this, as a medical school, the right place to train, or I think there is. But what's your perspective? What should we be learning?
I think it has to start from, when people are at their most acute and vulnerable place. As we see the hospital, people come in the highest distress. Normally, when you go to the grocery store, you're not going to see someone who's so distressed. Okay, so not to say this training platform can't be like cross disciplines or cross kind of even fields. We actually have people approaching us for HR training because whatever you're dealing with a customer, usually these scenarios are high stress. Okay, they're not like a normal daily conversation. You can have it with this, chatbot or the patient, but it's usually very high stress. And that's what we're targeting in humanity to lower and reduce their distress. It's not to take away our stress because stress is always going to be there, but we want it manageable and not pressured or overwhelmed. And I think that's a framework coming from it.
Very cool, unique to exciting stuff. We'll kind of follow up the discussion, but let's move on to Reenan. Do you want to start taking over the discussion? Clinical mind AI, another different way to learn essential knowledge and skills. Go for it.
Okay. So, hi everyone. My name is Reenan Oliveira. I'm an emergency physician, and today I will share how we are using AI to improve in clinical reasoning education through the Clinical Mind AI platform created at Stanford University. Okay. So, when we first started thinking about creating a platform back in 2022 to support health professions education, we asked ourselves a simple but fundamental question. What is something that all health professionals need to learn? And the best answer that we found was clinical reasoning. There are many definitions and frameworks for clinical reasoning, gathering patient information. For example, medical history, physical examination, and medical tests. And with that, we make decisions such as diagnostic hypothesis, treatment plans, refer or not refer the patient, and so on. Once we identify clinical reasoning as the key skill, the next step was to understand the challenges in teaching it. We spoke with universities and researchers worldwide, and several teams emerged. First, the format. Clinical reasoning is usually taught through short written case summaries, case vignettes, or scripts. Useful, but far from real life. Second, access and scalability. Simulation is a better approximation of real patient interactions, but is expensive, resource intensive, and hard to scale. And third, underrepresentation of expert practices. Elements like reflection, hypothesis generation, and reasoning process are rarely taught systematically because they require time, structure, and trained faculty. And these challenges were present across the entire continuum of training, from medical students to residents and continuing education. So we had three things: a critical skill, which is clinical reasoning, clear challenges in teaching it, and in 2022, the emergence of new technologies. And we asked ourselves, could AI help address these challenges in a scalable way? Perhaps we can create something to help everybody. And with that, we came to the idea that we could use AI to help address these challenges in teaching clinical reasoning. And that's how the idea of Clinical Mind AI began. But let's define Clinical Mind AI. It's an AI-powered learning platform that empowers customized AI simulated patients, provide real-time feedback to their student, and adapt to diverse medical curricula. The goal is not to replace teaching, but to give educators scalable tools to teach and assess clinical reasoning more effectively. We can adapt the platform to diverse medical curricula using the same technology. But when we explored the existing solutions, we found important limitations. First, language. Most virtual patients platforms were only available in English, limiting access. Second, lack of local relevance. Many systems provide pre-built case, but universities have different epidemiological contexts. A case designed for one region may not make sense elsewhere. And third, predefined metrics. Platforms often impose their own definitions of clinical reasoning and therefore decide what should be measured. But institutions may want to assess other competence aligned with their own curricula. So how do we change that in that platform? They already made those decisions for you. To address these issues, we built a platform that is language flexible, customizable, and curriculum aligned. The workflow is simple. First, instructor only does this one step. Creates a clinical case activity and choose the metrics they want to assess. The platform automatically generates the simulation. And then students interact with the AI simulated patients. The system analyzes performance based on these interactions. And finally, both students and instructors receive target feedback and reports. So instructors only need to complete step one. Everything else is automated. But what do we mean by a clinical case platform inside the platform? Clinical case activity can be many things. We asked many people what they understand by this concept. And we learned that educators define a clinical case activity in many different ways. Most want an interaction with a patient, for example, a chatbot-based simulation. But many also want activities before the encounter. For example, want to show a video or a summary, learning objectives, or do pre-questions. Others want activities after the encounter, like assessment questions or connect them to the electronic medical record so they can write something. So some instructors are more creative. They even want elements in between the history and physical exam, such as interactive materials or decision points. So we built a system where educators can create any combination of questions or interactions, so we can provide full flexibility. Instructors can create whatever they want, whatever the patient they input to the platform. We will create the patient for them and also even create the picture of the patient. Like here, as you can see, we generate all these images are AI generated pictures for these patients. If instructors prefer, students can also talk to the patient through voice, simulating a phone call. Or in some case, they want students to request medical tests during the encounter. And not only that, once they receive the medical tests, perhaps they want them to interact with these medical tests. So there are so many things you can do in this platform based on this resource we provide to instructors and how they can combine them. And at the end of the activity, students receive personalized feedback. All the scoring, descriptions, and criteria are based on what the instructors defined. So feedback is aligned with each institution's expectations. We originally thought the platform would have two users, instructors and students. It's obvious. But we realized that institutions also need control. So we create a third role, the institutional admin. Admins can manage accounts, course, and data, ensure privacy and security, and conduct research using the anonymized data sets. The project started at Stanford University, but over time, it has been moving throughout the world. We now partner with 18 universities actively using and contributing to the platform, collaborating with us. And there is something that I really want to highlight here. This project is made possible by so many people across the globe that has helped us knowledge and expertise. And thanks to them, we are creating something that everybody can use. We are also expanding access to simulation across the globe thanks to this project. And also we are open for everybody. So anyone who wants to contribute can reach out to us, and we can find ways to collaborate and expand not only access to the platform, but also do research with us and better understanding what we could do with artificial intelligence in medical education. Thank you so much for your attention. And to learn more or request an account, you can visit the link or access the QR code here. So everything is there in website. Thank you so much.
Great, thanks so much, Reenan. If anybody online or in the room has a question for any of our presenters, kind of a range and kind of many active systems. I don't know, but did any of these things exist 2 years ago? I don't think they did, right? There's such a rapidly moving capabilities. For what it's worth, I was at the AAMC Learn Serve Lead conference, a month ago, and there are multiple companies trying to do stuff like this. How do we wrap our heads around what to use, what not to use, and how do you evaluate whether something like this is actually effective or not? Why don't we lead it with Reenan and we'll cycle through. Like clinical mind, Reenan, clinical mind is cool. You can simulate patients. You can probably learn reason there. How do you prove that it makes an impact?
Sorry, I couldn't understand. Sorry. Can you repeat, please?
How do you know that clinical mind has the impact that you want it to have on people?
Okay, good question. So this platform has so many research and back on this. So we have partnered with a lot of universities, and we do research with them so we can measure the impact of the performance with the students throughout the curriculum. So some students, for example, that use the platform, the group that use the platform, or groups that don't, and so we can see they improve the knowledge, they improve the clinical reasoning too. Is that was the question?
Yeah. I mean, Dr. Chen maybe is similar thread. You can give the personalized feedback, but how do we know that feedback is actually useful? It could be AI hallucinations for all we know, right? How do you assess that to know if what's being done is helping learning, especially when learning is so hard to assess and measure?
Yeah, and I think it's right. I don't know if any of us know the answers. And thinking is so hidden, So I guess the two things that I would like to see in the future is education, whether that's medical education, higher education, K through 12 education, is a focus on thinking, on critical thinking. So that is one thing that we can observe and measure. And the other in clinical medicine, obviously the holy grail is that what we do here makes patients better. And I think if we have a focus on thinking, then all of us who are clinicians can make better decisions for our patients. And that can be measured in the way, much harder. But those would be my answers.
I think that, of course, that would always make sense at the end. It's very hard to do the attribution because there's so many levels of indirection to get there, even though we kind of just accept education as a good idea because it's so hard to prove that it matters, even though it almost obviously does. Maybe Dr. Ma, unless anybody else wants to raise a question of thought, especially because you're talking more about it's like communication skills. When you see somebody, you can tell when they're doing a bad job or if they're doing a good job. But how do you give target feedback? But it's hard to describe that, define that. And can that even be defined consistently? What is a good or a bad job for such a case?
Yeah, I think targeted feedback, it's tailored. And I think that's where we have the recording of verbal and nonverbal as an important piece too. It's not just you're practicing, simulating, you can also come back to it and have a recording and see your progress on it, right? I think there's a tracking of feedback. One of the things we're building on top of this that I didn't share yet because it's still in development is actually that all of us have to fill in these feedback forms when you have your residents, medical students rotate, but we're only seeing 20% of the feedback form coming back to the student and institution. The problem is providers are way too busy. And also then the students I'm not really sure. There's no consistent real-time feedback, even though the feedback was given. It's hard to remember all of that. So this is a way to give a good tracking of building real-time feedback that is recorded and also then feeding it back to an actual formalized feedback form the institution already has. And the institution sees it, the faculty sees it, the student sees it. So it's from all dimensions to really help support the learning of the students. What's good or bad? I think it depends on what this communication style is too. And like I said, case scenarios, context, those all matter. And that's why we don't have just set scenarios. We have a context that you can put in as promptly.
Sean Kuhn, would you like to add comments?
Sure. Can you hear me okay?
Yes, go ahead.
Yeah. Well, I think, a problem, perhaps in medicine or even in society is just, drifting away from that reflective metacognitive kind of experience about information that we receive or new products or any of these types of things. And I'm wondering if anybody's, run across any good evidence or research about what are the best ways to sort of induce any sort of reflective or metacognitive practice, especially now that, even though a physician may be an expert or a politician or anybody may be an expert, they may be facing the use of new tools like AI or many other new tools and capabilities that are emerging. So how do we help people to think in these critical ways once they've left, especially once they've left that sort of learning medical school residency venue?
Any representatives want to raise their hand? Looks like Dr. Chen unmuted. You want to go ahead?
I unmuted. I mean, I'll take a first stab at that. I guess my answer to it is that, you as a person, even if you're expert, if you have a growth mindset, you will continue to learn and grow. And, my coined phrase of a thinking mindset, in contrast to a growth mindset, if you have a thinking mindset, then it becomes more, you become more cognizant that you are using metacognitive, you're thinking about your thinking. All of these different thinking skills that I was presenting about, that you are more in tune with using those. So that would be at least my first stab at an answer.
Okay. Thank you.
Or you want to comment? You don't have to. Or we can go to the next question.
I would say, for at least in the psychiatry field, we have a lot of consultation. And that's why we have communities in that work. I think technology only should help boost that opportunity for gathering together and, giving you some observation, different perspectives on that metacognition. Maybe you had a rupture with a person. You're like, okay, this didn't really work well. Where did it go wrong? What could I do to change it? Those are ways that we can improve and start to change our cognition without just relying on the technology. But I think that's why you say it's platform tools to enhance rather to take away what humans already kind of do.
Right.
We're pretty much at time. Matt, well, Reenan, why don't you just have a final comment, and then if people, I assume all three of you are open to people reaching out to you for further comment, discussion, a lot of active development and cool things happening. Reenan, would you like to squeeze in one last thought, and then I will wrap it up. Reenan, would you like to
sure.
have a last comment?
Oh yeah. So I really like the question from Sin Kun. When we have already experts, how can we induce the reflection and metacognition? So this is a really difficult question, but I think using for example the clinical mind AI, we can create any kind of case and more complex case, and probably it's some way to provoke them to think more about and to these new clinical problems. And is one interesting thing that back to the platform, we can see how the students think or the questions the user do. So we can kind of see how can create this whole clinical reasoning back to the idea. Yeah.
Very good. Thank you.
Awesome. Thanks. A lot more to do, but thank you all so much again for our presenters and many innovative things happening in dynamic space. And hopefully I'll stay in touch again soon. Thank you, everybody. Bye.
Thank you.
We might not have a formal colloquium next week. There might be an informal one, and then we'll have the break for the winter break. And look forward to seeing everybody in January. Take care.
Thank you.